Wonderful.
Hi, Tanya. Good morning. This is Dr. Dharma.
Hey, Dharma. How are you? Good to see you again.
Good to see you. Hope all is well at your place.
So far, so good.
So far, so good.
So, Dr. Pankaj?
Yeah. Hi, Dr. Tanya. This is Dr. Pankaj Malhotra. I work at PGI Chandigarh, and I'm a hematologist here in the northern part of the country. Nice to meet you.
Very nice to meet you as well. I was actually born at PGI Chandigarh.
Oh, wow. That must have been long back.
Well, yeah.
Not so long back. Tanya didn't want to say it long back.
So you can't ask the age. You're not allowed to.
So let me share with everybody. Do you know the connection of Kamala Harris with Chandigarh?
Actually, I don't.
So the head of the Ops Gynae department, Dr. Sarla Gopalan, who headed the Department of Ops Gynae for almost 20-25 years in PGI Chandigarh. Kamala Harris is niece of Dr. Sarla Gopalan.
Yeah, because her mom's name is something Gopalan. Her last name is Gopalan.
Yes. So she has visited Chandigarh also.
Oh, very nice. Wonderful. Good to know. I'll share that caveat when I brag about Chandigarh.
Yeah.
Dr. Bhave?
Hi, I'm Abhay Bhave. I'm in Mumbai.
Very nice to meet you, Dr. Bhave.
Hi.
Dr. Nair? Chandan, are you there? Okay, we move to Dr. Sharad. Dr. Sharad, if you can unmute yourself and just introduce yourself.
Yeah, hi, Dr. Tanya. I'm Dr. Sharad Damodar. I'm a hematologist and BMD physician at Narayana Hridayalaya in Bangalore, trained at Vellore. And like Rahul mentioned, Biju is one of the teachers for all of us in this panel here.
Wonderful. That's so beautiful.
So Dr. Hari Menon has joined us. So the thing is, it's like this country has really moved on to the next level. People are doing genomics. Things from chaotic are becoming more orderly. There are more people. Dr. Chandan, just introduce yourself, please.
Hi, I'm Chandran Nair. I'm working at the Malabar Cancer Center, Kerala. I'm one of the hematologists working there.
Wonderful. Very nice to meet you, sir.
Dr. Hari. Is Dr. Hari there? So another 2 minutes, we'll just get rolling.
Yes, thank you, Rahul. Can you hear me?
Yeah, yes. We can hear you.
Yeah, great to be here. I'm Hari Menon, and I work currently at Bangalore. I was formerly at Tata Memorial. I was heading the adult hemato-oncology unit over there. So it's good to be here today with you all, and good to see all my good friends whom otherwise we would see more frequently at meetings. Yeah,
yes,
thank you.
Yes, absolutely. Absolutely. And I hope people, especially in Bombay and Delhi, I think, are staying safe. I know other places are hit too, but I hear more and more about Bombay and Delhi, I think, from the COVID perspective these days.
Yeah, it's sort of increasing down here in the south in Bangalore. Sharad will agree with that. The number of patients have quite exponentially increased, and we hope that some sort of plateau comes in soon enough. Yes.
So Dr. Ajay Sharma has also joined us, who is currently the president of Delhi Hematology Group. Dr. Ajay.
Yeah. Good evening, everybody. Hello.
Hi, Dr. Sharma. Good evening.
Good evening, Dr. Tanya. How are you?
Very well, sir.
So I welcome you all on behalf of Delhi Hematology Group and Dr. Rahul Bhargav, because this, I must say, is his big initiative that almost every week he is organizing one of the other meetings, and they're all more concerned with academics than I would say, the routine day-to-day practice. And I think it's a big encouragement for our junior residents to join the meetings, and he has done a great job. I congratulate Dr. Rahul, and with that, I think we should start with our proceedings today. We are all very eager to hear Dr. Tanya, and then after that we have a big panel discussion, which we will be seeing subsequently. So, Dr. Rahul, I would rather like you to invite Dr. Tanya for a talk, because you have done so much efforts in organizing this talk. Dr. Rahul, please.
Thank you, Dr. Ajay. Thanks everybody for joining in at this such a short notice, which was planned for 1 week back. So 2 weeks back, we hosted Vinay Prasad talking about the clinical trials. I think he has taken the US by storm, analyzing all the NEGM and critically reviewing every article and putting on Twitter. Then the last week we had on telomere length, understanding how the telomere and the telomerase works in, because it's a basic science understanding. This week, Dr. Tanya Jain is telling us how the mutations are going to shape our policies for myelofibrosis. She's the director for Adult Chimeric Antigen Receptor T-cell Therapy Program for Hematological Malignancies at Sidney Kimmel Comprehensive Cancer Center at this present moment of time. And rest you all know, you just have to Google Dr. Tanya Jain. I don't think she requires the introduction. But just to tell you, this is widespread geographical areas people are listening to Dr. Tanya. As far as from Mongolia, Cambodia, Myanmar, Uzbekistan, Mauritius, Iraq, Dubai, Kenya, Nigeria, as well as Uganda. So that's for where people are listening to, and they'll be shooting the questions. The panel discussion is not conventional panel discussions. All these are transplanters where the transplant runs into their blood. So they're going to ask you all sort of questions on which mutation, what to do. And Mr. Ram is joining from MedGenome. He's the CEO of MedGenome at this present moment of time, which is one of the largest centers doing for hematological malignancies, the mutations, with a turnaround time of 21 days. So that's the only thing. So over to Dr. Tanya, and let's have a great and wonderful academic evening. And one disclaimer, it's not being sponsored by any of the pharma players. There's no pharma involved into this at all. And on 28th, you'll be all welcome to join Dr. Saad Usmani for high-risk myeloma. So this is purely academic meetings which we are conducting. Thank you, Dr. Tanya, for your time.
Wonderful. Thank you. Thank you so much. It's so humbling, and I'm absolutely delighted to be here. And more specifically, I'm honored to be presenting on a pretty auspicious week for the Indian subcontinent on the whole, where we marked independence for, I think for the most part, the entire subcontinent. So I'm going to start to share my slides. Let's see here.
So in the meantime, Ganesh has joined in from Hyderabad. Dr. Bhau Baghel has joined in from Tata Memorial Center, Bombay, which everybody knows. The only missing is probably Dinesh Burani, who's missing right now at this present moment of time, who's a dear friend of ours. Okay, over to Dr. Tanya, please.
Wonderful. Thank you. Thank you so much again. So as Dr. Bhargava was mentioning, I actually recently started my faculty position at Johns Hopkins almost a year ago when I moved from Sloan Kettering, and I'm tasked with developing the myelofibrosis and the MDS-MP and overlap program here, more so also in the context of transplant. And a clone of me sort of takes care of the adult CAR T program here, which we're trying to develop from a relatively infantile program that it was last year. But that's not what I'm going to talk about. So what I'm going to talk about is exclusively on the role of transplant and myelofibrosis, and trying to focus that discussion towards what we know of the mutation data and how we try to use that mutation data. So we were taught to talk about our disclosures even when we talk to our family members. So here it is. They are not related to what I'm going to be presenting, except that BMS does make luspatercept which is being studied in the role of which is being studied to identify its role in treatment of anemia and myelofibrosis, but I'm not going to be talking about that either. So what I try to start with telling all my patients is that myelofibrosis, unlike some of the other hematological malignancies that we know of, it's not a single disease. It's a constellation. It's a disease spectrum, and it's made of various clinical features. Beyond cytopenias and beyond anemia, there is extramedullary hematopoiesis that ends up giving patients a significant splenomegaly, which causes a lot of symptoms. From the pro-inflammatory pathways that get activated in myelofibrosis as we know now, there are resulting constitutional symptoms that do bother the patients, that do affect adversely the quality of life of these patients. And these could include things like pruritus, fatigue, weight loss, and I mean significant weight loss, night sweats, etc. And as we have learned more about it, we now know that there are cytogenetic mutations that drive the biology of the disease. We have learned about driver mutations, the JAK, the CALR, or the MPL mutations that drive the biology of the disease. And we're learning more and more about the non-driver somatic mutations beyond the JAK, CALR, and the MPL that seem to drive the biology of myelofibrosis. Another way of saying what I already said is that it's not a single disease, it's a disease journey, and it's a relatively long, but also a relatively winding road in this disease, mostly marked by the chronic phase, which does occupy a majority of the disease phase, but can develop into the more aggressive form or the accelerated form. And finally, if you let it be, then it'll develop into a blast phase, or what we would technically call as AML or secondary AML emerging out of myelofibrosis. Even within the chronic phase, not everybody is the same. There are people who have what we think is a relatively low risk disease to the other extreme, which is patients who have much of that disease burden that I was talking about and are labeled as higher risk disease and probably at the verge of tipping into the more accelerated form of the disease. And it matters, right? Because their survivals are different. The survival of patients in the low risk disease, which is shown by the yellow curve, is much better than patients with a high risk disease shown in the red curve. And when they go to the blast phase, then the prognosis is dismal, for the lack of a better word. And this study that I highlight there at the bottom right corner was done 10 years ago. But probably is still not very different. The median survival in this study was reported around 3 months for patients in blast phase. It's probably not better than 6 months as an average survival for these patients at this point. So how this journey evolves at a molecular or at a cellular level is these normal hematopoietic cells, whether they go via clonal hematopoiesis or directly, first pick up a driver mutation, which is either a JAK mutation in exon 14 or exon 12, or an MPL mutation in the 515 codon, or the CALR mutation in exon 9. But all of these eventually lead to a constitutive activation of the JAK-STAT pathway, which, as we know, is a hyperproliferative pathway. Along the course of the disease, following this initial driver mutation, there are additional epigenetic events that happen, which could include picking up additional biological mutations, either as a chromatin modifier or a DNA methylation defect or a spliceosome mutation, which further define the aggressiveness or the biology of this disease. And eventually, either by a natural progression of what's happened so far, or as a result of picking additional terminal mutations, either in the TP53, which we all have heard of, we all know of as the baddest player in this entire heme malignancy spectrum, or even actually in the entire oncological spectrum, or the KRAS mutations or the NRAS mutations that eventually cause or end up resulting in what we call as a post-MPN AML. Now, transplant and myelofibrosis is always a conundrum. And if you make 10 myelofibrosis doctors stand up and ask them, they will have different views about transplant. So we all have very strong opinions and we all believe in them and we all like to fight about it. So it's all fun in our academia world. But here's what the reality is. So the reason we want to transplant patients with myelofibrosis is because of what I already showed you, because if you let them be, they will eventually develop into AML, and that AML that comes out of myelofibrosis is a very poor prognosis. Why we hesitate, or what is the other side of the argument, is that you kill people from transplant. There is around 40% attrition of patients, either by virtue of dying from the transplant as non-relapse mortality, or the transplant not working, so patients relapsing, and that number adds up to around 40%, leaving around 60% survival around 1 year, beyond which the curve relatively flattens out. Which is where the art of medicine comes in, which is why it becomes important to have better measures to identify these patients, the right patient at the right time in this long and winding road of myelofibrosis, to consider them for a transplant. We don't have perfect metrics. We will probably never have perfect metrics. But the more and more we understand the disease, the more and more we understand the patient, we will probably and hopefully will be able to make these decisions better. So some of the risk stratification methods, and with due respect to all of them, I use all of them in my clinic, but I will also state that all of them are imperfect. We started off with what we call as DIP score. Actually, we started off with IPSS score. It's just becoming more outdated and more difficult to put every single scoring system on one page. But the DIP score started off by attributing age, anemia, white cell count, blast count, and constitutional symptoms in the disease metrics, or the scoring metric. Then they added, when we learned about the role of karyotypic mutations, low platelet count as being a measure of the disease biology, and transfusion dependence, we added those factors and made it DIPS plus scoring system. And more recently, the MIP70, or the mutation enhanced prognostic scoring system, which has like 3 or 4 versions in and of itself, with due respect to Dr. Teferi. But that was the first scoring system that added these somatic mutations, the driver mutations, the high-risk non-driver molecular mutations, and even the bone marrow fibrosis severity into the risk scoring stratification. We wrote this a few years ago, but probably still holds true, the traditional teaching of how to think of transplant, or when to think of transplant. So you stratify them by one of these scoring systems. The 2 extremes sort of make sense. The lowest scoring system, or the lowest risk patients, probably benefit most from observation until they progress. And the other extreme, which is intermediate 2 or high risk, probably transplant should be at the back of your mind, or should be the intent from the get-go for all transplant eligible patients. And that is a very fluid term in and of itself. But you may need JAK inhibitors to prep them for transplant. You may need some investigational therapy to shrink their spleens and so forth before you take them to transplant. But the overall intent should be to try to take them to transplant. And then there is the in-between, the intermediate 1, which is probably the more difficult one, both when you read about it and also when you see these patients in the clinic. So this is where probably the role of mutations has the most benefit in terms of determining or predicting what their pace of the disease could be. For example, patients who have higher risk mutations or multiple high risk mutations would be thought to be more high risk and probably have a faster pace of disease progression. The other thing that we're learning or understanding more and more is that cytopenias or anemias or platelet or thrombocytopenia are some of the disease features that are not just cytopenias to put on the patient's chart, but define the aggressive disease biology when they are present as a result of the disease and not by virtue of their treatments and so forth. So when you see any of these high-risk features, I think it's not unreasonable to consider transplant. And I'll show you work that we did with CIBMTR that supports that. And again, following the same route as you do with the high-risk patients to tidy them up prior to transplant, but think of transplant, obviously, if they are transplant eligible. But what we want to talk about today more so is where do we fit these mutations as we make this decision? So I think I've tried to establish the concept of driver mutations here, which are usually the first event, and define the phenotype pattern of the disease. And the second thing being the non-driver somatic mutations. So let's talk about the driver mutations first. Even the 3 driver mutations seem to have a variable prognostic implications on myelofibrosis. So let's start with JAK2 first. So usually exon 14, V617F, rarely exon 12, but overall JAK2 is probably the most prominent driver mutation seen in around 60% of these patients. Certainly higher thrombosis than CALR and probably lower survival than CALR as well, at least in primary myelofibrosis. CALR, on the other hand, it's probably the second most common, the third of the driver mutations to be described by 2 groups at the same time, and both ended up being NEJM publications at the same time in 2013. And both sort of said the same thing, that most of the CALR mutations happen in exon 9. Most of them are frame shift mutations. The type 1, which is the most common, is a 52 base pair deletion, excuse me, and type 2, which is less common, is a 5 base pair insertion that we see. And there are several others that can happen, but all of them end up being a frame shift mutation and seen in around 30% of these patients. When you've seen enough of these patients in clinic, I think it's very easy to say that these are younger patients, they have a higher platelet count, and they do have a lower risk of thrombosis. Then comes the MIPL mutation in codon 515, seen in around 10% or so patients. But the marked feature of MPL mutated patients is that there is a lot of extramedullary hematopoiesis. So there is marked splenomegaly in these patients. And then what people like to call triple negative, and I believe that it's not actually myelofibrosis when it's triple negative, because the disease biology of what is called as triple negative is very different from the other 3. They are much high risk patients. They have much more cytopenias, they have much lower survival, they have a much higher risk stratification when they're diagnosed, and they clearly do more poorly than the other 3 of the more well-defined primary myelofibrosis. They almost behave as like the MDS and PN overlaps in the fact that they have a lot of cytopenias and a fairly rapid progression of disease. So, so in the form of some curves, so Dr. Teferi's group at Mayo showed this, that patients who have CALR mutated myelofibrosis do significantly better than JAK and MIPL, and the triple negative that I was trying to allude to earlier do significantly worse out of these 4 categories. This is all primary myelofibrosis patients. And even within CALR, the type 1 is the type of CALR that does better. The type 2 pretty much falls with the JAK mutation curve. All right, so now moving on to the non-driver somatic mutations. And there are several of them. We don't know the prognostic value of all of them. Even the ones that we know, we're learning more and more about them as we move further into the understanding of the disease. But highlighting this very simple depiction of these molecular mutations in the context of their DIP score, which was done by the Italian group, I'm going to focus only on the non-driver somatic mutations here. And if you look at the ASXL1, the SRSF2, and the EZH2, they're clearly more prominent in the high risk DIP scoring category, which makes you think that that it's probably by virtue of these mutations that the patients are in the high risk category. And if you look at some of the others, the DNMT2 and the TET2, or the DNMT3, I'm sorry, and the TET2, and they look pretty equally parsed out or even more prominent in the earlier risk disease. And that is, again, what we see and what the general teaching is, that they probably don't have a lot of prognostic implication, the DNMT2 and the TET2, even though they may have obviously some other implications in terms of how patients respond to some therapies and so forth. The IDH1 and 2 at the bottom is relatively infrequent, so it's hard to say, but I'm going to show you some more data to sort of tell you more about that. And this is what it is. So again, the same group, Alejandro Vanucci's group, they showed that ASXL1, which is a chromatin modifier mutation, SRSF2, which is a spliceosome mutation, EZH2, which is another chromatin modifier, and IDH1 or 2, which is a DNA methylation mutation. All of them, when they are present, or any of them that is present, they have an inferior overall survival. So the red curve is presence of any of these 5 mutations compared to the absence of all of these 5 mutations. And clearly they do worse in terms of overall survival as shown on the graph on the left. IDH1 and 2, however, more specifically have a quicker transformation to leukemia. And the curve on the right shows that the high-risk patients here are only IDH1 and IDH2 mutated, not the others, and they clearly have a much higher or a much quicker transformation to leukemia, which makes you think in terms of how they should be treated prior to transplant, especially in light of presence of IDH2 or IDH1 inhibitors. And all of these, correlations were true after adjusting for the IPSS and the DIPSS score. What they also showed is that 2 or more than 2 of these high-risk mutations in the same patient makes things even worse. And they showed this not only as a test cohort, but they also validated that from the Mayo Clinic cohort. And again, in these 5 mutations, they showed that the survival is significantly worse if patients have 2 or more of these mutations. And it is dramatic how that blue curve goes down in the first 2 to 3 years in terms of overall survival. And I think that is very telling and something to keep in mind when you see these patients. At least in my clinic, I have a bunch of these, and I don't wait to take them to transplant if they have a real hotspot mutation in 2 or more of these high-risk mutation phenomena. All right, so this was about what I talked so far was about how the mutations talk in terms of dictating the biology of the disease. What I want to talk about now is how these somatic mutations, if at all, talk about how they're going to affect the transplant outcomes. And the data here is more sketchy, but I'll show you what we have. So the German group, Dr. Kroger's group, showed the mutational landscape of around 200 patients at their center or in their group who underwent transplant. And if you leave out the JAK, MIPL, and the CALR, the top 3 there, you see that ASXL1 is the most prominent. The U2AF1 is fairly prominent. The SRSF2 is fairly prominent. And if you go down a little bit more, there's a lot of EZH2, or at least some of EZH2 that got transplanted. And the reason for that is probably because these patients had a more aggressive disease, which prompted the physicians to think to taking those patients to transplant. What they also showed is that the patients who have CALR mutations, both type 1 and type 2, did better in terms of overall survival. And that was mostly dictated by a lower non-relapse mortality. And that's interesting, right? I mean, you think CALR is dictating the disease biology. So I would expect CALR mutated people to do better because they relapse less. But what you're seeing here is that they have a lower non-relapse mortality. So that probably doesn't make sense. But one way to think about it is that patients who have the CALR mutations, they are fitter at the time of going to do transplant. They have less comorbidities by virtue of having had myelofibrosis because the CALR mutated patients have probably a less aggressive disease. And by virtue of having a better comorbidity status at the time of transplant, they have a lower non-relapse mortality. And this is what those curves look like in that the CALR mutated patients had around 10% non-relapse mortality compared to around 30% for the non-CALR mutated patients, as shown in red and blue respectively. ASXL1, which is probably the baddest player that we know of in this entire heme malignancy spectrum, at least in the myeloid space, and not surprising at all that they had a higher risk of relapse when present. As you see here, probably at least 10 to 15% higher risk of relapse, 2.5 by the hazard ratio, 2.5 times, I mean, by the hazard ratio. I would add, though, that not all ASXL1 mutations are created equal. At least in the non-myelofibrosis myeloid malignancies, we see that it's the frameshift mutation that cause a bigger damage compared to the other ones. In MDS-MPN overlap, on the other hand, when they look at ASXL1, either as a frameshift or a missense or a stop codon mutation, they all seem to do bad. In myelofibrosis, it's slightly less well understood because most of these studies did not tease apart the frameshift compared to the others. So for now, how we look at it is all of them are the same, but I think there is special mention to it when the ASXL1 is present as a frameshift mutation. IDH2 mutated patients were very few in this study. I think there were only like 5 patients, but they did seem to have a lower progression-free survival as well. Now, this is data from an American study, which was a multi-center study led by Sloan Kettering, Ronnie Tamari there, who's a friend and a colleague, or a former colleague, I guess. They showed that the high-risk mutations that we know of did not seem to impact overall survival. In fact, even the MIP70, the original version of the mutation-enhanced scoring system, did not seem to impact. And 3 versus, or less than 3 versus 3 or more number of mutations did not seem to impact overall outcomes. What they did see, however, in the multivariate analysis is that patients who receive a reduced intensity conditioning do worse than patients who receive a myeloablative conditioning. Now, I would add that not everyone can receive myeloablative conditioning in myelofibrosis because the median age for diagnosis is around 65. And beyond 65, it's not a wise decision to be using myeloablative conditioning in those patients. The donor type, this has been shown before and continues to come up, that unrelated donors do worse than related in myelofibrosis. In terms of mutations, what they found was that the patients who had the U2AF1 mutation, which is also a spliceosome mutation and has been shown by the Mayo Clinic group to be a high risk, even in terms of the biology of the disease, seem to do worse in terms of transplant outcomes as well. And then the DNMT3A mutations seem to do worse. And I think that partly is because it's sort of a measure of clonal hematopoiesis that happens in these patients. So it's not a de novo mutation, probably. And then finally, this is data from City of Hope, which showed that mismatched MUDs do worse, not a surprise. CALR, ASXL1, IDH don't impact outcomes. Again, mudding the picture all over again. What they showed was that CBL mutations did worse, and U2AF1 had a higher non-relapse mortality. And they also looked at the stratification based on the MIP70 version 2.0, and they showed that patients who had a lower risk disease seemed to have a better overall survival compared to patients who had high risk disease based on the MIP scoring. So let me just recap a little bit. What we had so far is we have a risk stratification based on the various morphological features, the hematological features, some of the mutations, all of these censored at transplant. What we did not have was a way to risk stratify these patients in the context of transplant. And this was done by the EBMT group, who developed this comprehensive clinical molecular transplant scoring system, or MTSS, as it has come to known as, using patients with both primary and secondary myelofibrosis for the first time, and included transplant-related factors in determining outcomes in their I think 300-something patient study. So included factors like age, performance status, platelets, leukocytosis, mismatched donor, all of these were high-risk factors. In addition to the presence of ASXL1 mutation, which we have seen was a persistent thing, and the absence of CALR or MIPL driver mutation. So either JAK2 or triple negative were considered to be high risk. And both in their training cohort and in the validation cohort, their estimates were true in that the low-risk patients did better compared to patients with already high-risk disease based on this scoring system. What was different in this from the other studies is that more than 2 molecular mutations did not seem to impact transplant outcomes compared to what we know about the disease process. U2F1 did not impact outcomes, even though both the City of Hope study and the multicenter study from America showed that. The conditioning intensity did not seem to impact outcomes, again, something that was shown by the multicenter study. And is also actually being shown by other groups as well. So it's intriguing that their study did not show that difference. But the only shortcoming of this would be that patients, or they were not able to include patients who were treated with ruxolitinib. So all these studies are the pre-ruxolitinib era studies because the ruxolitinib follow-up was relatively short and not available for analysis. So I've told you data from, I've sort of spread the data all over the place. So it deserves a summary slide here in terms of what we know about mutations dictating the transplant outcomes. And it's all over the place. It's not clear. The Kroger group says the CalRs do better. Tamari's group says U2F1 does worse. City of Hope group says the CBL do worse. And the EBMT data suggests the ASXL1 do worse. Although I would say that the ASXL1 is fairly, it makes sense biologically, and it does show some similarity in some of the studies. Now, what we don't know is how this stands. So what do we do now? What we do now is we find another group with a lot of patients, because a big limitation of all these studies is low number of patients and the variability of mutations. So it's hard to sort of plot them and make a statistically significant model out of it. So we found a bigger database. We found the CIBMTR database, which has over 600 patients. And the intent is to use the validation the EBMT cohort as a validation cohort. And this is also being led by Dr. Ronnie Tamari, and we're participating in that as well. So if I were to ask myself if mutations are the end game, I think in terms of dictating transplant or the decision to transplant, probably yes. But I think we're still limited in terms of using the mutations in terms of determining what's going to happen after transplant. So if I were to go back to my journey slide and define the role of transplants somewhere starting off from the intermediate to high, I think we understand the role of driver and the non-driver somatic mutations better in the context of the disease than in the context of transplant. So moving beyond this, what we're doing at Hopkins is that we are asking a couple of specific questions beyond just the presence of mutations or presence or absence of the mutations. So we're looking at the disease or the mutation allele burden at the time of transplant from our banked samples retrospectively in our myelofibrosis and overlap patients who underwent transplant to understand if it's just the presence or absence of mutation that matters, or if it's also the allele burden reduction that matters. And this is happening as a single center study at Hopkins in the context of our PTSci or post-transplant cyclophosphamide platform, but also as a multi-center collaborative effort via Myeloproliferative Neoplasm Research Foundation. The second question that we're trying to answer, which I tried to allude to earlier, was if targeted therapy, for example, IDH inhibitors, have a role prior to transplant in myelofibrosis by reducing the mutation allele burden. And I think that's an important question because it will certainly dictate how we treat these patients with IDH mutations in myelofibrosis. So I have a couple of patients who we've treated with IDH inhibitors. One of them, we gave him IDH inhibitor prior to transplant. It shrunk his spleen. He was able to go to transplant. Unfortunately, died post-transplant from transplant-related issues. And the second patient we've started on, who's not a transplant candidate, but he was progressing on JAK inhibitors in the way that the white cell count was going up. So we've now started him on IDH inhibitor, IDH2 inhibitor, and axitinib, and we'll see how that controls his disease, specifically in terms of time to leukemic transformation. So briefly, we talked a lot about mutations, but what's beyond mutations here? I mean, how else can we make transplant better? And can we make it better and safer so that it's attractive to offer? And what we've done, some of the things that we've done is to compare some of the reduced intensity conditioning regimens. And actually both us, when I was a fellow at Mayo, and also Dr. Kroger's group in Germany, have shown similar data that patients with Bu-flu conditioning do better in terms of non-relapse mortality, but clearly the relapses are higher if you compare to flu-mel, which is 5% relapse, and patients, more patients were alive, but there is definitely more non-relapse mortality with the flu-mel based regimen. The FBM regimen, which is the first pie chart, is the flu, BCNU, and melphalan, which is, I think, used fairly limited outside of Mayo Clinic, but it was also on the side of a more aggressive conditioning regimen. What we're trying to do at Hopkins is we use a lower intensity conditioning, and our non-relapse mortality here is of the order of 10 to 15% at 6 months. Obviously that concerns us for disease control post-transplant. So we're opening, or I've written a trial for using a minimally toxic maintenance regimen, which could potentially boost the graft versus leukemia effect, which we know works in myelofibrosis. So to use that as a maintenance strategy to prevent relapse despite using a non-myeloablative conditioning regimen. What's more beyond mutations is the time to transplant, which I hinted on my tweet yesterday, that we do transplant people very late in the course of the disease. And this is data from CIBMTR, which is a study that was led by my friend and former co-fellow at Mayo, Christina Gowen, and I was a participant in that, where we showed that in a cohort of thousands of patients, as you can see, patients not only with intermediate 2 and high risk benefit long-term from transplant, which is a red curve, but also the intermediate 1. And this is, granted, this is dip scoring, so it does not account for mutations. A few things to note here are, one is that you cannot take away the initial attrition from the non-relapse mortality from transplant, and that is a big problem. And that is what we are trying to address by using a reduced intensity conditioning for these patients. The second thing is that, again, emphasizes that none of these scoring systems is perfect. And we need to understand these scoring systems in the context of the patient, in the context of each patient. And lastly, I'm talking about maintenance. I'm sort of deliberately throwing that in there, but I think we know that not everyone needs to be put on maintenance. Not everyone can be put on maintenance. And this is another study that I did as a fellow and was recently published, where we showed that at day 100 post-transplant, if you're transfusion dependent, or if you have an unfavorable molecular status, which was defined by either a less than 100% or less than complete donor chimerism, or the presence of driver mutation, you do worse. And if you have both of these factors, you do even more poorly. So perhaps these are the patients to focus on when you're thinking about transplant strategies, which even though they may be minimally toxic, but they will never be non-toxic. So to save patients who do not need maintenance, to save patients from that toxicity, while using it in patients who we know will have a higher risk of relapse or a higher risk of poorer outcome. And finally, which we should never forget, is the clinical judgment is paramount, beyond scoring systems, beyond what you read. It's the patient who tells the best story in the clinic. And it is always important to understand what the patient wants, what are their life perspectives in terms of moving forward with a transplant, meaning compromising 6 months to a year of their quality of life in an attempt to get a better overall life or a longer overall life, versus using the quality time that may have now, and even if that may be short. And that is really a patient's decision. Our job is to sort of help them make that decision rather than make that decision for them. And as a former mentor, actually still a mentor. Sergio Giralt, who I'm sure a lot of you know at Sloan Kettering, he's the director of transplant at Sloan Kettering, but he always used to say that transplant is never a necessity. It is always a patient's choice, and it's not for us to decide who and when should go to transplant. With that, I'm going to end. I'm happy to take questions. I hope some of you are still awake. I know it's late in the day, at least in India.
Thank you, Dr. Tanya. So over to the panelist, and then I can ask the questions on the chat, which are there. So Dr. Rao is there from MedGenome. Dr. Tufan has joined lately. Dr. Dinesh Burani has joined. Dr. Ganesh has joined with us. So please, you can ask your questions. You are the hardcore transplant physicians of this country. So please go ahead and ask your questions. And Dr. Biju, Dr. Pankaj, and the rest of the people can actually moderate this session for asking the questions. Please.
So Biju here, let me start by with the question session. Tanya, that was a lovely talk. I think it clarifies a lot of things, although I understand that in the space of mutations, there is still a lot of things which are not very clear. I had two questions I wanted to ask. One is, when you look at the natural history of progression of myelofibrosis, it's clearly understood that there, other than the driver mutations, the non-somatic mutations may be present at the time of diagnosis, but subsequently it will increase at the time when you progress. So one, is there any role for serially monitoring them, and does that come up before you it actually reflects in the blood counts? And the second question was with regard to TP53 and its impact on how we transplant myelofibrosis.
So I think phenomenal questions, both very important clinically. So the first one I think talks about serially monitoring the mutation status. I think the way I use it, and not to say that's right or wrong, but the way I use it is kind of how I use the marrow. Even though you can monitor mutations in peripheral blood in myelofibrosis, because these mutations are present in all granulocytes, you don't need blasts to pick these mutations. So the way I have used it is any change in the clinical pattern of the disease. So if they're becoming more cytopenic, or if their leukocytosis is getting worse, or the blasts are changing, I think that's the time that I have used to check if they have picked up another mutation that is now driving or dictating the disease pattern. In terms of TP53, I think what we do know is very clear from Rampal's paper in PNAS a few years ago, is that it is definitely much more common in patients when they progress to AML. It's probably like less than 3% in chronic phase MPNs, but more than 10% or around 10% in patients when they progress. So when I see someone with a hotspot TP53, and again, all TP53s are not equal, as we know. So if it is a hotspot TP53, I become nervous if that doesn't make me look any bad. But I think those are true to be considered for a more transplant-directed treatment guided by their blast count. So if they are in the accelerated phase or close to 20% blast, then I think you're thinking of a relatively aggressive treatment, either AZA-VEN or at least AZA by itself, before you take them to transplant, because you want that blast count to come down in the marrow, right, before transplant. And if they look like they only have, a few blasts and not really aggressive disease, I think then all bets are off in terms of shrinking their spleen, getting their counts a little better, plus minus AZA, and taking them to transplant like you would do for a regular myelofibrosis patient.
Okay. Just one last question regarding conditioning for myelofibrosis. Again, there are two questions. One is, any experience with using triosulfan, because we have it available in India. Two, we have now started using total marrow lymphoid irradiation in ALLs, where we are looking at increasing the intensity of TMLI even up to 18 gray. So do you think there's a role for using total marrow irradiation in myelofibrosis, because the toxicity actually is quite low?
So I'll answer the second one first. In terms of the total marrow irradiation, I haven't seen any data in particular for in myelofibrosis particularly. I think the question there would be, how is that going to impact the fibrosis in the marrow? Because that is all that matters in the marrow for these patients. Even though the grade of fibrosis itself has not been shown to impact before or after transplant, the outcomes of transplant. But I think when you see these patients in the clinic, the degree of fibrosis does correlate to some degree with their count recovery. So if you're able to improve the fibrosis, and I'm not sure if marrow irradiation would do that, in fact, it may even make it worse. I'm not sure. It'll have to be studied in a clinical trial context to know better. I think we'll need a better hypothesis for this. In terms of treosulfan, I personally don't have much data, but I think the studies, as they have used it outside of specifically the context of myelofibrosis, they've sort of used it equally with the other alkylators. So I would think that it should be reasonable to do that if you're using with your other backbone of conditioning regimens.
Thank you.
So are there any other panelists before they shoot their question? They're on the chat box. So we have got few people from Bangladesh who has joined in late and from Nepal. So Dr. Sumit has asked a 40-year-old male with JAK2 prefibrotic myelofibrosis with IgA nephropathy, 5-gram proteinuria, no HR mutation and NGS, intermediate 1. Question, can ruxolitinib or allo-SAT be recommended for his paraneoplastic manifestation, but otherwise a low-risk disease?
So if he's technically pre-fibrotic, and I'm assuming you say that based on a low degree of fibrosis and some megakaryocytic dysfunction on the marrow, and not necessarily a lot of cytopenias, I'm not sure I would rush. The other thing is the IgA nephropathy as a paraneoplastic from myelofibrosis is not really common. I mean, I wonder if there's another reason for this nephropathy that needs to be evaluated. For this proteinuria or the nephrotic syndrome that this patient is having. It may not even be a heme malignancy etiology, maybe something infectious or otherwise, which I would say be evaluated before we use that as a reason to take this patient to transplant. I mean, he's 40, which is relatively young, and it's only, if it's only really pre-fibrotic, I would probably not be in a rush to do that. And let me clarify, the role of ruxolitinib in the myelofibrosis is not to reverse fibrosis. It is not to improve counts. The only thing that ruxolitinib helps with is shrink the spleen or improve constitutional symptoms. So if your patient has that, then by all means, yes, it is something to consider. But ruxolitinib is not going to help either a paraneoplastic presentation or the counts or transplant outcomes for that matter. So you have to sort of think of it in context of what ruxolitinib does.
So Tanya,
Rahul, I have a few questions. Hello. Dr. Rahul,
Dr. Dharma is first. Dr.
Yes,
Dharma, please
Dr. Dharma, please.
Yeah, Tanya. So if a patient who is on ruxolitinib and spleen is really, really big, do you consider anything before transplant? First question. And if you need to do transplant on ruxolitinib, so how long you will, like what time point of view you will stop before transplant?
So again, great question. So spleen reduction prior to transplant, what I don't know, or what we don't know, is what is that magic size of the spleen that will make someone's transplant outcome better, right? I think we have begun to understand, though, that a bigger spleen is a marker of an aggressive disease biology. So the spleen does need to shrink and also to allow engraftment. So the first line, the FDA approved, quote unquote, or the regulatory approval agents are ruxolitinib. There is fedratinib, which is commercially available now in the United States, which works in around a third of the patients who have not responded to Jakafi or even after Jakafi or ruxolitinib. But I think those patients should really be treated on trial. So some of the options or some of the promising data from ASH this year was the BET inhibitor, the constellation BET inhibitor, the CPI-0610, which I think was phenomenal in terms of shrinking the spleen in combination with ruxolitinib. There was navitoclax, which is also, at least in the early phase data, seems promising. There is the KRT232, which is an MDM2 inhibitor, which we're opening the trial here for in combination with ruxolitinib after patients stop responding to ruxolitinib itself. So I think this has become the pattern everywhere in the United States to use these drugs for spleen shrinkage. And by the way, there is the Masarova paper in Blood last year, which uses Rux plus AZA, and they see a decent amount of spleen shrinkage at around 24 weeks. So that has been the strategy, to use drugs instead of using splenectomy or radiation. I will tell you, I have used radiation 0 number of times in my life, which, I haven't had a very long career, admittedly, but I've seen it in the whatever years I've done this, I've seen it 0 times. Splenectomy, I have done a few. In our Hopkins data, the 5 people who had a splenectomy, all 5 of them relapsed. And I think that's why I say that the big spleen, which requires a splenectomy, is a marker of the disease biology, or it seems like it's a marker of disease biology. But those are some of your options, depending upon what you can get your hands on. The Rux pre-transplant is a very important question, and I think even though it sounds simple, a lot of us do it differently. But I, at least until now, I taper my ruxolitinib off by the day prior to start of the conditioning. So I use that week from my consent visit to the start of their conditioning, which is usually a week apart, and I use that week to taper their ruxolitinib off. Harris Ali from City of Hope has presented at ASH their data in terms of keeping ruxolitinib until day plus 30. There are people who have started using it. I know at Mount Sinai, Alla Kiesner has started to use that now. But I think I haven't really wrapped my head around what's the utility of that. I mean, ruxolitinib is a myelosuppressive drug. So why should I give it in an early post-transplant phase when my patient is starting to engraft? Plus, if they don't have issues with spleen or symptoms at that time, which most of them should not, because you've given them a lot of conditioning and they're all myelosuppressed by that time, I shouldn't need Jakafi. So I'm not sure what Jakafi is adding in the early post-transplant period, but at the same time, it has shown to be safe if you wanted to use that.
Thank you.
Perfect. So good, Dr. Tufan. So there's Dr. Dastan from Iraq, which has joined in just now. She can ask, because myelofibrosis, we do quite many from Iraq for transplants. And Dr. Dastan is in Erbil doing a wonderful job doing 120 transplants in Italy, along with Italians. They have done and established a transplant in Erbil in Iraq. So, Tufan, please go ahead.
Yes. So one very simple question from my side, Dr. Tufan here from Kolkata. The simple question is, sometimes the myelofibrosis patient require the transfusions, and down the line we can go ahead with the transplant also. So any data in terms of the transfusion dependency, and the number of the transfusion and the transplant outcome? This is the one question. And the second question is that sometimes the people has a myelofibrosis, sometimes has a blast between the 7 to 10% into the bone marrow. So in terms of the outcome of the transplant, between the high risk without blast and myelofibrosis with blast of the 7 to 10%, any difference into the outcome in transplant?
So great questions. The first question is, does transfusion dependence prior to transplant seem to impact outcomes of transplant? And the short answer is yes, but the transfusion dependence is, if you look at the DIPS plus score, and if you look at some of the other scoring systems, it has made its way in terms of independently determining prognosis of the disease. So I think it is fair and safe to say that transfusion dependence means that your disease is more aggressive, whether it's platelets or anemia. The other thing is, when you have patients who are transfusion dependent, meaning they have very low platelets or very low hemoglobin, it is very difficult to use JAK inhibitors in those patients. So the way both ruxolitinib and fedratinib have been studied is patients with platelets above 50. And we know that everybody's hemoglobin goes down when you start them on these JAK inhibitors, at least temporarily. So treating them is a problem. So I think patients who are transfusion dependent are to be considered high risk and candidates for transplant when they are transfusion dependent. I don't see a huge impact from iron overload, even in sort of the chronic phase of the disease, or even in the context of transplant. So I don't rush into starting them on iron chelators prior to transplant. You can take care of that after if you need to. Your second question was patients who have 7 to 10% blast in the bone marrow. So 7 to 10% blast in the bone marrow is different from 7 to 10% blast in the blood. The reason I mentioned that specifically is because a lot of times when you run the flow from your marrow sample, it's a hemodilute sample, and the 7 to 10% that you're seeing is actually the blood blast and not actually the marrow blast. So the first point is to make that differentiation and make sure that is actually a real marrow sample, because all of these marrows are fibrotic and difficult to aspirate. So a lot of times what you get is pure blood anyway. But if you see 7 to 10% on flow, and then you also see 7 to 10% on morphology of the bone marrow, then that's real. And that probably needs to be addressed before you go to transplant. I haven't seen a study that looks at less than 5% versus more than 5%. But I think it's a reasonable determination to make to take the patients to transplant in a response or in a complete response, the definitions of which includes less than 5% blast. So my effort is to take them to transplant with less than 5% blast. You can achieve that with azacitidine. A few rounds of azacitidine will get you there prior to transplant. And it's immune suppressive. It allows you to use a lower intensity conditioning regimen. I think it's a win-win to use a couple of cycles of azacitidine in these patients.
So Tanya, if you are not in a rush, then we can extend it by 10 minutes because there are plenty of questions to answer.
Sure. Yeah, I'm okay. I'm okay with that.
So,
I have one question.
Yeah, please.
Sure, this is Ashish here. Hi.
Hi, Dr. Ashish. You are the first one to join in. So Dr. Ashish is from Manipal. Please go ahead, Dr. Ashish.
Oh, wonderful.
Hi. Yes, but it's not KMC Manipal. I'm in Bangalore. So, yes. Right. So my question was related to the when do you consider a graft failure post myelofibrosis if there is no shrinkage of the spleen? Or what's the timeline for the spleen shrinkage that you see over a period of time? Is it 1 year, 6 months? And second question is, in case you have to use ruxolitinib for a chronic GVHD, whether the tapering schedule is going to be different, or does it respond differently or causes more myelosuppression?
So the first question is spleen shrinkage post-transplant, I'm assuming, right? When do you expect to see that? So the goal, as I was trying to allude to earlier, is to try to take them with a smaller spleen to transplant. So we don't have to worry about spleen shrinkage post. But if you had, let's say, a 15 centimeter spleen that you were going to transplant with, which is completely reasonable, the spleen shrinkage, the marrow fibrosis improvement, the counts improvement in myelofibrosis does not happen quickly. It takes several months, more than 3 months to happen. And when we looked at our day 100 data that I showed you, that transfusion dependence and molecular status was prognostic, these things were not prognostic. So we looked at spleen size in that study. We looked at myelofibrosis grade or improvement in myelofibrosis, and it didn't seem to impact outcomes the way they were present at day 100. So I think it does not matter. The other aspect of the spleen shrinkage is also what you use for your conditioning. So you will see a more quicker spleen shrinkage if you're using a more, a higher intensity conditioning regimen. So your the high BU flus or the big BU flus will probably shrink them quicker than the Flu-Cy TBI 400 that we use at Hopkins. So I think, there are different aspects to it that matter, but I don't think it matters unless your spleen is growing post-transplant. I don't think I would worry too much about it staying the same or shrinking slowly. The second question was in terms of how to use Rux, or is the use of Rux different in GVH post-transplant in myelofibrosis patients? And I wouldn't think so. I mean, the only thing that would limit that, and I have a patient who had a pretty decent GI GVH, and it seemed like she was not responding actually, she was responding, but she developed this nasty hypertriglyceridemia from steroids plus tacrolimus, which is our usual way to start treating them for higher grade GVH. So we had to come off the tacrolimus and the steroids. And we tried to use Jakafi on her, but her platelets were so low that I couldn't use Jakafi on her. I couldn't dose Jakafi on her. She was in the 20s. So I think that's a problem. Fortunately for her, her GVH sort of, continued to respond even with the steroid taper. So we didn't have to use Jakafi. But I think as long as your platelets are fine, I don't think I would use it any differently. I think the dose for GVH is around 10, and I think that shouldn't be a problem for the most, as long as there are some platelets, probably even around 50, I wouldn't hesitate to use the 10.
Tanya, moving on to the next question. Place of haploidentical transplant in myelofibrosis, Dr. Prashant Mehta, who is an avid transplanter, compulsive transplanter, I would say, in North India, a wonderful guy who sings wonderfully well. Sometimes we'll have a pleasure of listening him. But what is the place for haploidentical transplant? And Vidya, who does are all genomic standings in the country, does rare types of CALR mutation and the cytogenetics have a different prognostication? And Prashant we have already answered how to check and low risk mutations. Please, first these two questions.
So I'll answer the CALR first because I'm opening my data set for the haplo in myelofibrosis. So I'll show you the actual figures instead of speaking. But you invited the wrong person to talk today. It would have been a much entertaining talk if we had someone who was singing instead. Anyhow, so CALR, the rare ones, I think in the context of transplant, they have always clubbed the type 1 and the type 2 and the other rare ones together. So, and they haven't seen, or at least none of the studies that specifically looked at it, none of them showed a difference. So I am tempted to say, although lacks evidence, but I'm tempted to say based on an extrapolation that the CALR, the different types of CALR probably don't matter in the context of transplant. In the context of disease outcomes, I think type 1 is the one that does better and not everyone else. So I don't think everyone should be, I don't think everyone has an equal CALR mutation. In terms of the haploidentical data, I have this in a relatively raw format, but I'll show it to you anyway. Let's see how I can share my screen again. So this is our data. This is the Hopkins data, if you can see this, which does not look very different from some of the other reduced intensity data. So the Hopkins data, when I say that specifically, I mean that we use flu-cy TBI. We have now started using exclusively peripheral blood graft in these patients and not a marrow graft because of some engraftment issues with the marrow graft. And as you can see that the median overall survival at 2 years is around 70%, which is comparable to every other single report that you pick up from myelofibrosis. And this curve goes as far out as 8 years, and obviously not many patients are available for that follow-up, but at 2 years, there's a 70% overall survival. What we are improving on is this relapse rate, which also is not very different from the other studies that you look at, but the relapse in myelofibrosis remains around 30 to 40%. And again, this varies because everybody uses a different definition for relapse. Relapse in myelofibrosis is not as well defined as we know in AML and other diseases. And our non-relapse mortality at 2 years amounts to 20% or so, and probably at 6 months is probably around 10 to 15%. So that is a gist of haploidentical outcomes. I would also direct your attention to an ASH abstract that we submitted as a collaborative study between 11 centers across the United States and North America, with Princess Margaret included, and we show that marrow grafts do inferior, and in addition to that, we sort of show the description of the outcomes, which look pretty similar to our Hopkins outcomes, probably because half of those patients in that study are ours anyway. So, Siddharth Kunti, who's a fellow at Cleveland Clinic, I had the opportunity to mentor him on that project. So he's the first author, and I'm the last author on that abstract. But that's something to look at when the ASH abstracts come out.
So one question is, do you use JAK2 allele burden post-SAT as a preemptive marker for starting any therapy or DLI? If yes, what level of allelic burden are you comfortable with? So this allelic burden, does it make you sure before transplant? If somebody has got 84%, would you like to have a different view than a 24% of a JAK2?
So this has been studied. So there's a paper from Al-Shalbi several years ago that showed that the allelic burden, the JAK allelic burden, we didn't know about MPL or CALR at that time, but they looked at JAK allelic burden prior to transplant, and that it did not affect outcomes. They looked at it as a continuous variable. They also looked at it in 4 quartiles, and it didn't seem like that was making an impact. Which is why when I showed you what I'm doing here, we're not looking at the driver mutation allele burden, because we don't think that allele burden is what drives the aggressive nature of the disease. So no, I do not worry. I probably worry about the high risk mutation allele burden, which we do believe probably dictates the biology.
So simple question, do you recommend screening of mutations for non-driver somatic mutations along with JAK2, KLR, MPL at MF for MF at baseline?
Yes,
simple one.
I always. Yeah.
So Vidya and Ram,
I mean,
please.
it's pretty easily available. If it's not easily available, then I think it's a different question. I think you could wait until you're seeing something changing. But it's easily available for me, so I do it on everyone to get a sense of what the prognosis is going to look like.
So it is available in India and it's not very costly. Dr. Paramjit Dhot from Toronto is asking any role for cord blood transplant in myelofibrosis. Probably in India we are not doing so. Just a small answer for that.
No, I wouldn't. Memorial Sloan Kettering, which is a big cord blood center, also does not use cord blood transplants for myelofibrosis.
So role of HMA post-transplant in case of myelofibrosis with blast crisis?
That's a variable spectrum answer. I think it's not unreasonable to do, although I think there is no evidence to support that. But I think a lot of times, as you know, we treat ourselves and we actually treat patients based on data. So I think it's one of those things where we treat ourselves if we do it. But I don't think something's wrong.
So probably the last question. 32-year-old female, triple negative, U2AF1 mutation positive, myelofibrosis, DIPS intermediate 2, has a matched sibling donor. What conditioning would you advise? Any post-transplant maintenance?
So she's very young and it's very unfortunate. Transplant makes sense. If she's 32 and in a good shape, I think it's not unreasonable to consider a higher intensity conditioning. I would tell you though that we here probably would not do that, but I think it's there is a paper from EBMT group in BBMT last year that clearly says that myeloablative conditioning does have better outcomes in terms of disease control. And if she's that young and assumingly healthy for her age, I don't think it's unreasonable to use a higher intensity conditioning, probably like a big flu. The data on maintenance in myelofibrosis is all clinical trials. There is no defined therapy for maintenance in myelofibrosis at this time. So I don't think I can recommend anything outside of the context of a clinical trial that may be available to you.
Dr. Rahul, can I ask just a last question before we conclude?
Please, Dr. Ganesh, please go ahead.
Yeah, it was a wonderful talk, Dr. Tanya. We thoroughly enjoyed and a lot of insights on myelofibrosis. It's such a difficult transplants in the clinical practice. Just a couple of questions. A lot of patients we see who are triple negative myelofibrosis, the pathology report is consistent with myelofibrosis, megakaryocyte, mostly pre-fibrotic myelofibrosis, megakaryocytic clustering, atypia, no lymphoid infiltrates, seronegative for all autoimmune workup. And, and then because till now we didn't have the practice of getting the non-driver mutations and the entire spectrum of the myeloid panel by NGS as a routine. So what is your take on such seronegative autoimmune myelofibrosis, which might be sometimes be confused with pre-fibrotic triple negative myelofibrosis? That is one. Second is, madam, like one of the eminent panelists has asked, this is a common issue post-transplant. The non-shrinkage or suboptimal shrinkage of the spleen, poor graft function. So how will you go about managing such cases? Splenectomy, stem cell boost, or second transplant? So we have a couple of such cases where it's a real tough issue. The chimerism shows persistently more than 95% donor chimerism, and the persistent cytopenia, splenomegaly. So persistent splenomegaly, cytomegaly, and then a few of them have minor major blood group mismatch. So many a times erythropoietin and all this used to decrease the transfusion frequency, but then what is the final solution of such cases? And the third one, for all huge spleen myelofibrosis patients, do you do upper GI endoscopy as a routine, to rule out the portal hypertension in such cases? And if there is a portal hypertension, how do you differ in your management in terms of transplant for such cases?
So, just because of my memory, I'm going to start with the last one first.
Yeah.
But the GI endoscopies, we don't routinely do that. I mean, there are, portal hypertension, pulmonary hypertension. These are some of the aspects of myelofibrosis that can happen. But unless otherwise clinically indicated, I don't always get them to do a right heart cath or an upper GI endoscopy to look for what their pulmonary pressures are and what their portal pressures are. In terms of graft failure, I think that's a relatively open question. For example, I have a patient whose counts are lowish. He's not necessarily transfusion dependent, but he also does not have a big spleen, and his counts are taking forever to come back. He's beyond day 100. But I think at this point, I'm just waiting because he does have 100% donor chimerism, and the hope is that new immune system, once it matures, it will have that ability to kick off the fibrosis in the marrow and sort of actually start the hematopoiesis. At MSK, we have done CD34 selected boosts in some of these patients. That is a pretty challenging process because it requires equipment, it requires expertise in being able to select the CD34 cells, and obviously requires donor availability as well. But you need, if you have a functioning Miltenyi device, then you can select the CD34 cells and infuse that without any bridging chemotherapy, and the rates of GVH with that strategy are pretty low. Obviously, assuming you're able to filter out the T cells pretty well. DLI usually will not help much in these, I think, but if the chimerism is sort of going down and your counts are not coming up, then I think that's a place where DLI may or would have a role. Or if you have a persistent JAK mutation, then I think that definitely has a role. Second transplant is not easy in myelofibrosis. There are not many people who are able to get it. There are not many people who make out alive of a second transplant in myelofibrosis, mostly because they're older. Younger patients, definitely yes, and we have had some of those, or a handful of those, but it's not an easy question. And I'm sorry, I didn't pick on your first question pretty well. You said the difference between sort of
younger patients with younger patients with triple negative myelofibrosis, pre-fibrotic PMF versus seronegative autoimmune myelofibrosis.
Yeah, so I mean, if they are triple negative, and if they have, I mean, I think you need to look at what the disease is doing to them, right? Is it causing cytopenias? Is it causing symptoms? Is it causing splenomegaly? And I think if that is happening, if it's impacting counts, if it's impacting quality of life, I think those are some of the things to put together and see that this has a minimal impact or a major impact to consider whether these are optimal for transplant or not. I think we use the pre-fibrotic myelofibrosis a little loosely because, in all honesty, it's not very well defined, right? I mean, even if you look at the WHO criteria, it's hard to define. It's hard to tease apart what's ET and what's pre-fibrotic and what's early stage myelofibrosis. So I think if you're calling pre-fibrotic, I'm assuming you don't have constitutional symptoms and you don't have a huge spleen and you don't have a lot of cytopenias. And I wouldn't worry much about that. But if what you're saying pre-fibrotic is actually early phase myelofibrosis and has constitutional symptoms and has splenomegaly and has the other stigmata of myelofibrosis, then I think that's asking you for an intervention.
So Dr. Tanya, is the splenomegaly a hindrance for you for a transplant? Whether it regresses, whether it does not regresses, pre-transplant, post-transplant, if that is a hindrance for you pre-transplant, would you go for a splenectomy?
So we're trying to do splenectomies fewer and fewer. We do want to shrink spleens, but we do splenectomy less and less often because there are more and more drug therapy options that have the potential to shrink the spleen as opposed to taking them to surgery. I mean, remember, splenectomy, at least the way it was described, there was a 10% mortality rate from the splenectomy itself, and that's not little. That's not insignificant. There's a 30% comorbidity rate and there's a 10% mortality rate. So you don't want to take them to a splenectomy and then make them ineligible for a transplant altogether. I mean, I think it's a bit of a double-edged sword when you think of that.
Dr. Tanya, one more question. Just this is a practical question in our routine case scenarios. A patient presenting, because we didn't have a habit of doing NGS in all our PMF cases, whether it is CALR negative, whether JAK2 positive or negative, intermediate 2 or high risk PMF, starting with intermediate 2 or high risk, and then whatever intervention, mostly the ruxolitinib, and then eventually 6 months, 1 year down the line, the DIP score, not the DIPS plus or MIPS, but DIP score goes down to 0. So he goes to low risk, and then it is very difficult for these patients to convince to proceed for transplant. So what is your practice when the patient having no either not having the at diagnosis NGS panel, but starting with a intermediate 2 or high risk disease, young patient having a fit transplant eligible, and then eventually over a course of time, with appropriate intervention, he is going to fall into low risk or DIPS 0 or 1. So do you continue to pursue to take such patients for transplant?
So I think that's a great question. And the DIP score, the D in the DIP stands for dynamic, right? So it's a dynamic scoring system, meaning that it can change with your medications and it can change with your interventions. And that change is important because if you are bringing him to a lower risk, meaning let's say their transfusion requirements improved or their constitutional symptoms improved, that's important because you can now stall them for probably longer, which runs into a very classic question of at what phase in my ruxolitinib treatment do I transplant them? Do I transplant them at the peak of their response, or do I transplant them when they're starting to lose response to ruxolitinib? And that used to be a more difficult question when fedratinib was not available, because now even if they're losing response to ruxolitinib, I can give them fedratinib and try, hope for that response, and probably half of them will do that, and then take them to transplant. I think the second kick around, there's no reason to wait. The first kick around, I would try. I mean, I'm a transplanter, so maybe I'm biased, but I try to take them at the peak of their response, especially if they're young, especially if there's a lower prediction to non or relapse mortality. And lower does not mean 0, obviously, but it's always that risk-benefit analysis. So if someone is young, healthy, and probably would be expected to have a lower non-relapse mortality, then I think it makes sense to consider them for transplant at the peak of their response.
So with this, just a pressing question has come by saying, if you have a spleen which is size increased, you do use a different CD34 dose than a person who does not have a large spleen? Between
not
6
necessarily.
and 10?
I mean, we try to use more than 2 in everyone, much more than 2, I guess. 2 is sort of the lower limit. But no, we don't usually aim for a different CD34 dose if they have a bigger spleen.
With this, we come to an end. Our digital partner has been WebRx, who has been providing all these solutions for all of us. Wonderful creatives. Over to Dr. Pankaj for a vote of thanks.
Okay. Thanks, Dr. Rahul and Dr. Tanya. On behalf of all the panelists as well as the attendees, it is my pleasure duty to thank you for the wonderful talk. And I would again reiterate your last slide that in myelofibrosis, the patients tell the story, and
Absolutely.
Transplant is never a necessity. It's always a choice. In fact, we recently published one of the review article, and we made kind of a scoring system, DRAM. We use the word DRAM, which is dynamic risk assessment methods. That, it's not, at the time of when you see the patient, when you make a diagnosis, you take a decision at that time. Don't take the decision at that time. Follow the patient.
Absolutely.
Look at, at 3 months, 6 months, and 1 year. And then, the patients will tell you this story. I really thank you on behalf of everybody, and maybe we see you more often. I have 2 more connections with you while listening to you. One is I worked in Mayo in 2005, and I worked with Dr. Michael Morrow in 2010 in Oshu, who is in Memorial Salon Catering, and Dr. Vikas Gupta in Princess Margaret again is from PJ Chandigarh. So
Is that
there are a
right?
lot
I
of
didn't know that. Okay. Very nice. Very
so
nice.
there a lot of connections.
I'm building this Chandigarh cloud now. I mean, I didn't know about him, but you obviously know Navneet.
Yes, Navneet Majhel is from Chandigarh. Dr. Nitin Jain's in-laws are from Chandigarh.
Oh, is that right?
Dr.
I know
Nitin
Nitin
Jain.
Jain. I didn't know his in-laws were from Chandigarh.
Yeah, and lot of people actually from have Chandigarh connections. So
And Rishi at AIMS is originally from Chandigarh too. Rishi.
Yes, he was my student in PGI. So he studied in PGI Chandigarh for his fellowship.
Yes, and you know Arjun Law as well, who's now at
Arjun was among the first fellows from PGI Chandigarh. Yeah.
Wonderful. It's a small world, and I'm glad we're getting connected. It's just so humbling to sort of reconnect all the way back.
Yeah. So thank you so much, and we will see you maybe little more often, and I take your permission for that. Thank you so much.
Absolutely. Happy.
Thank you, Dr. Tanya. And I think all the doctor needs to be on Twitter, because that's how I got in touch with Tanya. And wonderfully, she accepted the invitation and speaking to this August audiences. India is growing in numbers. Transplant numbers are growing. More of evidence-based medicine is creeping in now in the Indian system. So wonderfully, thank you, Dr. Tanya. See you everybody on 28th with Dr. Saad Usmani. Keep your questions ready on high-risk myeloma. I'm sure you're going to have fireworks on that day between Dara and Kyprolis. So see you then on 28th. Till that, stay safe, stay blessed. Thank you, Dr. Tanya. Thanks a lot.
Thank you, Dr. Ravi. Thank you, Dr. Tanya.
Thank you.
Thank you, Dr. Hari, Dr. Ashish, Dr. Ganesh, Dr. Pankaj Tatia from Bikaner. Thanks a lot.
Thanks, everyone.
Thank you very much.
Thank you,
Dr.
Rahul
Ajay
and everybody.
Sharma, who has been forefront for organizing all these things. Thank you, Dr. Ajay. Thank you.
Thank you. All the best.
Absolutely. Take care, guys. Bye.